Good afternoon, everyone. Thank you so much for attending our Lunch and Learn webinar on migraines. I'm proud to present Dr. Stephen Factor on behalf of Abington Neurological Associates. Dr.
Hello,
Factor.
everyone. My name is Dr. Stephen Factor. Does everyone hear me? Things are good with the audio? Okay, good. So I am incredibly honored, privileged, and it's a great pleasure to spend an hour with you today at lunch to talk about migraine, really kind of go over the clinical features of it, give a background of its pathophysiology briefly, and talk about management. It really is a golden age of migraine care right now, and it's important to carefully kind of go over the management decisions we make in today's clinic setting. Of course, not every management decision will be specific to you, and you can go over this with your particular practitioner, but it's good to have a general overview of everything. I would like to thank ANA for giving me this opportunity and for all the patients that come here that have helped me kind of fine-tune this clinical decision-making process. So just a basic overview, we'll first start talking about diagnosing migraine, the pathophysiology, which is basically the biochemical background to why migraines happen. And then we're going to switch gears a little bit. We're going to talk about management, both abortive treatment and preventative treatment. The idea of preventative treatment is to decrease the number of migraines you get per month so that abortive treatment will be more effective and not cause anything like a rebound headache or medication overuse. And then in the end, we're going to go over some clinical trials that are currently active and enrolling patients at Abington Neurological Associates. So what is headache versus migraine? Headache, first of all, is actually the most common presenting symptom in our neurology clinics. It's incredibly common, and a vast majority of headache patients get migraine attacks. And no two migraine patients are alike. Some people have mild migraines, moderate migraines, severe migraines. Some people have an associated aura, about 30% of patients do, and other patients don't have any associated aura, never have an aura in their entire lives. Some people have 3 migraines a month, some people have 25, some people have daily persistent migraine headache. There's a huge spectrum of migraine disorders, and headache is just a small part of the migraine experience because there's, like I mentioned, the aura experience. There's also a prodrome and a postdrome, which we're going to touch on in just a moment. But as I just mentioned, headache is a severe issue, and it's so common in this country as well as the world as well. 39 million Americans have migraine in this country, and extrapolates into a really notable annual total cost. It takes a huge dent in our GDP. $36 billion every year are being spent on migraine care and treatment, and that equates to a 70% higher healthcare cost to migraine affected families as compared to those who do not have migraine. So when a patient comes into an office with a headache, right, we don't quite even know if it's a migraine yet. We have to, number one, make sure it's not due to something else, meaning, is this a secondary headache? Is this due to, God forbid, some kind of space-occupying lesion in the brain, a tumor? Is there some kind of aneurysm? Is there a venous sinus thrombosis? Or is there, for example, is somebody going through a Sjogren's flare, some kind of flare of their autoimmune connective tissue disease, something? Or is this something that just happens to be worse due to some environmental triggers, some kind of worsening of their baseline migraine characteristics for a particular reason that we have to work up? So number one, figure out if whether or not the headache or migraine is due to something else. And number two, our second main job as neurologists is to figure out to what extent is this headache disabling your life. And then we cater our abortive treatment and preventative treatment to treat that end. So how do we diagnose this? Well, there's no specific blood test and there's no specific imaging study to specifically figure out whether or not you have a migraine. It is a clinical diagnosis. The history and exam is the gold standard of diagnostics here. The blood tests can help, figure out whether or not there's an associated trigger or maybe a vitamin that can be replenished or something like that that could be contributing, or of course, as I mentioned before, something that's causing some kind of meningeal irritation right outside of the brain. But more than anything else, the most important thing is a clinical diagnosis via history exam that oftentimes is sorely lacking in outpatient family practice clinics, internal medicine clinics, and many neurology clinics as well. So to be cold and empirical just a little bit, let's look at the International Classification of Headache Disorders criteria, the third edition of it, and figure out what exactly a migraine is. So there's 4 primary criteria and there's 2 secondary criteria. The 4 primary criteria of a migraine, and you don't have to have all 4. You actually have to have 2 out of the 4 to classify as migraine. It has to be of unilateral location, of pulsating or throbbing quality, of moderate to severe pain intensity. It feels subjective, but a migrainer knows when their headaches are really bad. And it has to get worse with any kind of movement. Now, if you have 2 of those 4, you're well on their way to the diagnosis, but there's a little bit more. There's secondary criteria as well. There's nausea, which is frequently more severe or more notable when the headache itself is a little bit more severe. And then there's photophobia, which is the sensitivity to light. And there's phonophobia, which is the sensitivity to sound. Now, if you look at a lot of past studies, photophobia is often considered, apart from pain, the most bothersome symptom in a lot of patients. We're visual creatures. That makes a little sense. But phonophobia, the sensitivity to sound, a lot of patients don't really voluntarily bring that up during the patient visits. You have to pull that out of them. But when you ask a patient during a migraine headache, do you want to listen to loud music? Do you really want to put headphones on and listen to thrash metal or anything like that? They'll often say no, because they actually are more sensitive to sound than they're initially willing to give credit for. So you need to have one of those 2, photo and photophobia or nausea, in addition to the other 2 primary criteria. So where the heck is all this migraine stuff coming from? What is the underlying pathophysiologic biochemical basis? Well, it's super complicated. It's a little bit beyond the scope of this lecture, but the cortical spreading depression is kind of this wave of depolarization that moves really slowly, about 2 to 4 millimeters per minute across your brain surface. And it's thought to be the kind of biochemical basis of the migraine aura, right? And it's known to activate pain signals in the trigeminal nerve, which then releases all these neuropeptides and causes meningeal irritation, sometimes mild vasodilation of the blood vessels, and then goes back to trigeminal nerve and causes even more pain signals and activation of this migraine cascade. So, and that causes more than just a headache. Remember, migraine is more than just a headache. It's a migraine attack that encompasses what we call a prodrome, an aura, the actual headache phase, and then you got this kind of recovery resolution phase that we can kind of jumble into the postdrome, right? So this prodrome is when certain neuropeptides are activating, for example, the hypothalamus, where you get these food cravings. And for example, thalamus, where you get this kind of cognitive slowing, fatigue, malaise. And then you move into the aura period. Some of you, not all of you, right? You have these 5 to 60-minute periods of visual sensations or sensory sensations, which we'll go into in a little bit. And then that evolves at times into a headache, an actual headache that we talked about the details just recently. After 4 to 72 hours on average, that's kind of the spectrum of chronology of time that it can last, you can move into this postdrome feeling when you're feeling really kind of tired and hungover. You can have a little bit of diuresis. You urinate a good deal. Some of these things are kind of subtle, but you can see how long it can take for a patient to really get over a migraine attack. So what about these auras? And I admit I'm kind of a visual person and I love art, so this stuff really kind of grabbed my attention. And as a migraine patient myself, I've been suffering from migraines without aura since I've been 9 years old, but never had a migraine aura. This stuff really fascinates me. This is actually caused by the cortical spreading depression moving really slow along the surface of your brain. The visual auras are the most common and are affected or created by this little wave of depolarization, almost like a little seizure, but it's not a seizure. We put electrodes on the brain, on the scalp, I should say, and we don't see any evidence of seizure activity. But this is a drawing that was made by Hubert Airy. He was kind of this romantic scientist in the late 19th century, and he drew the evolution of his visual aura over the course of about 30 minutes. And you kind of see this kind of scotoma in his peripheral vision, this blurriness with the jagged lines around the side, which is also kind of illustrated in this modern computer-generated image here. You see the periphery of that blurry vision, and you have this kind of jagged lines. This is called a scintillating scotoma, which is again represented in the 70s with an oil/watercolor, painting. I'm not sure exactly what that is. And this is initially published in Oliver Sacks's book, Migraine, that came out in the early 90s. And you see a similar image here with the scotoma in the right visual field as well. And they're different auras. There are vertiginous auras. There are sensory auras, where this sense of numbness and tingling can migrate from the shoulder all the way down to the fingers in about 20 to 30 minutes. And then afterwards, of course, you get the headache pain. So it's different from a seizure. That migration in a seizure will be a few seconds. It's different from a stroke, where you don't have a headache afterwards. There's no associated pain. Stroke is a sudden onset focal neurologic weakness without any associated pain. These things are different. In very rare cases, we'll see motor weakness, which is just weakness, right? In the arm or leg. That can be seen in familial hemiplegic migraine. We do have some patients with that specific to one particular gene abnormality. Weakness is a predominant migraine symptom. The reason why it's so rare is because they believe between the somatosensory cortex, which is highlighted and labeled in this kind of cartoon image here, and the motor cortex, which is right in front of it, there's something called a Sylvian fissure. And they believe that this anatomical substrate somehow inhibits the passage of that cortical spreading depression, and thereby a large percentage of patients with sensory aura only have the sensory aura and not the subsequent motor manifestations. So why in the world do we get these pesky migraines, right? No one gene is responsible. It's a whole host of genes beyond the scope of this particular lecture. And there are epigenetic factors involved as well. So those are environmental influences on our DNA. But there are triggers, right? When we've got this unfortunate genetic predisposition, we're a little bit more sensitive to a lot of potential triggers for migraine. Temperature changes, red wine, cheese, caffeine, aspartame, sugar, psychological stressors are incredibly frequent. When estrogen levels drop precipitously during menstruation, that triggers migraines. Sleep deprivation, fasting, dehydration, all these things together can do it, or singularly can do it. No patient is the same, but we all have to walk through this gauntlet through our migraine lives. With respect to explaining frequency and how to kind of put ourselves into certain, not boxes, but kind of categorize patients as far as episodic versus chronic. Episodic migraine is defined by 0 to 14 migraine days per month. Chronic migraine is greater than 15 migraine days per month. And you have to get this diagnosis, experience this for at least 3 straight months. And you can go back and forth. 2.5% of patients experience a movement from episodic migraine to chronic migraine per year. It stinks. It's terrible. We try to figure out why that's going on. Sometimes we'll order imaging. Sometimes we'll do a great deal of blood tests, figure out if you've been put on any new medications. And then A little bit of good news, chronic migraine can remit to episodic migraine in 26% of patients over a 2-year period. So, maybe this is due to improvement in preventative therapy, we're hoping. And it's preventative therapy is required in chronic migraine. It's also frequently used in episodic migraine as well. So let's talk about the management of migraine, acute treatment, preventative treatment. Let's get into it. So there's a lot of inappropriate treatment out there, both in neurology clinics and family practice clinics and pain management centers. The guidelines do recommend the use of triptan drugs, Imitrex, Naxol, Frova are just some examples, and ergots like Migranol for acute migraine treatment. Yet a lot of medications that contain opioid drugs and barbiturate drugs are frequently overprescribed. There have been many studies that have shown this. 46% of adolescents in one particular study happened to receive an opioid. That is a remarkably high number of adolescents getting this drug. A population sample of over 4,700 adults with migraine were prescribed opioid, who were prescribed abortive medications, a third of which were opioid medications. And greater than 15% adults with migraine meet the criteria for acute medication overuse. So there's clearly an unmet need here. We have clear guidelines to use other medications, yet doctors and other kind of extended providers are throwing these old drugs to patients to treat migraine pain, and these are not the optimal therapeutic modalities. So triptans, since the late 80s, early 90s, have become the most widely used abortive therapy for migraine. But it's unfortunate because a lot of patients can't take these drugs. For those for whom it works and it's safe, they're amazing. You're looking at one of them. But there's another unmet need here because a third of patients don't respond to it. 43% can't tolerate these medications because of the side effects. Sometimes they cause neck stiffness and tightness, chest pain, flushing sensation, a lightheadedness. And a lot of times they can cause recurrence of symptoms. Patients take more medications, can cause rebound headaches, but most importantly, they're cardiovascular complications because these drugs vasoconstrict. They can narrow the arteries in your neck and intracerebrally. So there's concern about use in patients with prior cardiovascular disease. So we need a new kid on the block, and we got one a few years ago. But the beauty of these new calcitonin gene-related peptide blockers was that they're the only new specific drug for the acute migraine treatment with proven clinical benefit that actually alters the migraine treatment pathway. You've got these opioids, for example, that just treat pain generally. They don't actually affect the migraine pathway effectively, right? Triptans were introduced in the early 90s. They're agonists of the serotonin receptor because a lot of times serotonin levels drop during migraine. Give a triptan, serotonin levels go up. That's a very minimalist explanation, but it's somehow descriptive of what happens. We do know that in migraine, CGRP levels at rest are higher in those with migraine. And then during the actual migraine attack itself, they go up even more. So there is a good deal of evidence for the efficacy, both of preventative treatment to keep those CGRP levels down, and then abortive treatment with CGRP blockers to treat those exacerbatory events. So what are these abortive treatments, these abortive GPAN treatments? GPAN specifically, these are small anti-CGRP molecules that block CGRP at the receptor site. So CGRP is coming to the receptor site, the GPAN is in the way, and it is unable to attach to the receptor and thereby unable to cause a migraine cascade that causes migraine pain. That's the effect. So these are small drugs that are taken orally, came on the market within the last year or two, that are very effective at decreasing acute migraine pain. So one of them is called Ubrelvy. The other one is called Nurtec. Ubrogepant and Rimegepant are the generic names respectively. They are both oral tablets. Ubrogepant comes in 50 and 100 milligram doses. They have different half-lives. Ubrogepant lasts for about 6 hours. That's the half-life, Rimegepant is about 11 hours. Rimegepant, as a result, can only be taken once a day, whereby Ubrogepant can be taken twice a day as long as you space out the dosing every 2 hours, max twice a day. That's very similar to the dosing regimen that you saw in, for example, sumatriptan. So we're making the drug companies are making the transition easier, especially for those who have the cardiovascular complications or those who can't tolerate triptans for other reasons. The side effect profiles for these drugs are quite good. They're very tolerable, especially at the 50 milligram Ubrogepant dose. It's pretty similar to placebo in the original studies. About 2% of patients experience some dizziness or nausea, and 2% somnolence. At 100 milligram dose, it's 4% nausea, 2% dizziness, 2% somnolence. Rimegepant is pretty similar. Rimegepant is also approved for preventative purposes. You can take it every other day. I have had some patients complain that that's a little bit confusing. They often forget to dose it every other day. The other Gepant drug that's being used for migraine treatment, but not abortive treatment, preventative treatment, to be taken every day is called atogepant or Qulipta, which is quite effective and uses the same kind of mechanism of action as Ubrogepant. It blocks the CGRP receptor, and it is an oral tablet. And it's often used at the 60 milligram dosing unless you have some severe liver or renal disease. But it has a longer half-life. The half-life is about 12 hours, and thereby you can use it as a preventative drug. The other newer abortive therapy is lasmitinib, and the brand name is Rayvow. It is a ditan, and to kind of simplify this, it is a selective serotonin receptor agonist. It does what the triptans used to do. It says 5-HT1F. It's a little complicated. The triptans were 5-HT1B, 1D. This is similar. It's a similar receptor to the triptans, but it does not have risk of cardiovascular complications. But there's a rub here because there are more side effects with this drug than the Gepants. Dizziness is seen in about 15 to 16% of patients. Paresthesias, which is kind of numbness and tingling in the arms or the legs, seen in about 6%. Fatigue, nausea, somnolence, 3 to 4%. And most importantly, in the initial studies, patients experience some impaired simulated driving performance at about 1.5 hours after the initial dose. So the concern is that they can't drive after taking this medication or operate heavy machinery safely. So the FDA recommended, or mandated, I should say, not driving or using heavy machinery after taking this medication for 8 hours, which severely limits the use case of this medication. We often use this medication for maybe nighttime headaches or headaches on the weekend when you know you won't be getting behind the wheel. For those who don't like drugs, and we have patients like that, who don't like to take oral drugs or inject drugs, we have drug-free abortive migraine relief. Nerivio is a relatively new FDA-approved, smartphone-controlled, wearable, non-invasive device. It aborts migraine attacks. It is not a preventative medication. It's an abortive medication. So when you have a headache, you would open up the app after wrapping this Nerivio device on your arm and start a 45-minute approximately treatment period. And the initial studies by Unitsky showed that stimulation with this particular device was more effective than sham stimulation, so fake stimulation, in achieving pain relief. And that's a pretty notable difference versus placebo, 67% versus 39%. And placebo is usually stronger in studies that look at devices. So it has been pretty effective in the studies. I found in my personal clinical practice, it's rather binary in its effect. Some patients love it. Some patients think it's a sham, to be quite honest with you. But, you know, it's worth trying it. And it also, I haven't noticed that it's better in episodic migraineurs versus chronic migraineurs. It's really just worth a try either way. Combination therapy. This really kind of harkens back to the initial notion that every patient is different. The more we see you, the more follow-ups that we have with you, the better we learn about you as a patient. And the better our discretion in treating you is, whether it's a triptan plus NSAIDs to abort your migraines, a GPANT plus a sumatriptan, maybe adding an anti-emetic or anti-nausea agent and adding on that drug-free wearable device to abort your migraines. Possibilities are endless. The more information you give us, maybe with the addition of a headache log, will help us help you identify your ideal therapy. And now let's switch gears a little bit. We talked about abortive migraine care. Let's talk about preventative care. And the idea that's backing this is that if you have a lot of migraines and even more than 3 to 4 per month, preventative therapy should be discussed, especially based on the American Headache Society's new guidelines of, hey, listen, we need to possibly shift prevention to focusing on limiting progression to more migraine days. But the old preventative drugs were really kind of drugs that were used for other things. And whether it was for depression, for beta blockade, for control of heart rate, for seizures, Topamax and Depakote or Divalproax really kind of ring true, but the side effects are notable, right? You have Depakote, which causes hair loss and weight gain, metoprolol, propranolol, and timolol are beta blockers that can cause exercise intolerance and lightheadedness. Topiramate can cause, the brand name's Topamax, some people refer to it as Dopamax, can cause cognitive slowing, numbness and tingling in your extremities. Amitriptyline is another drug that's strongly recommended by the Canadian Headache Society as a preventative, but it can cause urinary retention, constipation, blurry vision, cognitive slowing. These drugs were not designed specifically to affect the migraine pain cascade. When they were trialed for other things, the patients in those particular studies or the participants in those studies noticed that their migraines were getting better. So then they did some other studies and found, hey, this could be helpful. But we need better therapy because as you use these drugs, sometimes the side effects are intolerable. When you titrate up, that becomes difficult for a lot of patients. And they're not specific to migraine therapy. So we're looking for better treatments. And this is where the CGRP monoclonal antibody drugs come in, which can be used in episodic and chronic migraine with or without aura in the adult population. We looked at the GPANTs in this right column, which are small molecules and can be taken orally and really attached to the CGRP receptor to prevent that migraine pain cascade. And one of those GPANTs has been approved for episodic migraine preventatively, right? That was the Qulipta or the atogepant. But we also, for a long period of time, have had these CGRP monoclonal antibodies, which are subcutaneously or intravenously given to the patient. And administered to the patient. These are large molecules, so you can't swallow them. They're not oral medications. And they either attach to the receptor or to the actual CGRP protein neuropeptide specifically. What is a monoclonal antibody? It's basically a man-made or a lab-made molecular structure that kind of acts like your autoimmune process and attaches to the receptor. And it's kind of got this like biochemical DNA in it, man-made DNA to create a specific effect on this migraine pain cascade. Going into the specific example, actually, let's talk about the general side effects. The injection site reactions are very, very common. In fact, the most common side effect with these drugs, oftentimes I've noticed that it's due to patients not thawing out this medication, which needs to be refrigerated at all times prior to use. Oftentimes patients thaw it out for about an hour or two, and then they get this kind of large welt, this swelling, maybe a little bit of bleeding, and it can last for a few days. And prematurely, we can switch to a different medication because we think that could be a medication failure or more commonly side effects that are intolerable. What I would recommend in those situations is to let this medication thaw out for maybe 4 hours, 6 hours to reduce the risk of that kind of side effect. With respect to the first drug here, Aimovig, it's been out for the longest period of time. It was the first monoclonal antibody monthly injection drug to come out. It blocks CGRP at the receptor. Most common side effects that we've seen, as I mentioned, was the injection site reaction, but also we see some nasopharyngitis and some constipation with this drug specifically. We often don't use it in patients with high blood pressure as well. Some benefits to this drug, it's 2 separate doses, though I have seen the 140 milligram dose be the most effective as compared to the 70 milligram dose. The injector itself is probably the best of all 3. I think it's easiest to use. Emgality is a drug very similar to Aimovig, but it blocks CGRP at the ligand, which means at the neuropeptide itself rather than where it attaches. You get 2 injections at the first clinical visit, and then you get 1 monthly. You don't have to come in for clinical visits for this drug. You can give it to yourself or have your loved one give it to you. This also has another indication for cluster headaches, which are not migraines. They're a little bit different. Side effects are somewhat similar. We don't see as high a frequency of constipation on this drug. And then we have Jovi, which has a higher amount of fluid in it. So I do personally see slightly more injection site reactions with this particular drug. And this one blocks CGRP again at the neuropeptide rather than at the receptor site. This has the added benefit of being able to be given 3 injections every 3 months for those who travel a lot. It's just an added convenience feature. We call that the triple pack. We would never start out with that. God forbid you have a severe reaction to it. So we'd probably start out with 1 per month just to judge tolerance before starting on a triple pack. Vyepti. So Vyepti is another CGRP monoclonal antibody, much like the 3 that I just mentioned. However, it is an infusion. This is not something you can do at home. It is something that you would get infused at a clinical center, like Abington Neurological Associates. We perform this infusion here all the time. It is a 30-minute infusion that's performed every 3 months. Studies show efficacy after the first infusion treatment. It's rather well tolerated. Only 2% of patients have some stuffy nose, itching, flushing sensation, some hypersensitivity reactions, and it's usually only seen on the first day of dosing. We often go through the 100 milligram dose first. In rare cases, we can bump it up to the 300 milligram doses if the patient is tolerating the medication, but is not receiving an optimum level of efficacy. If insurance isn't allowing ANA infusion, there are other infusion providers that can do this, but there is this small but non-negligible risk of anaphylaxis. So we usually would give you an EpiPen if there is a risk of anaphylactic shock or reaction. But of course, this is something that we would discuss at length with you before moving forward with this. So it kind of goes back to this idea of oral preventative medications, the older oral preventative medications. Are they still effective? If we've got all these like new models, right, to look at and use, especially if those don't work, right? What do we do? So there's a push by companies, I'm sensing, of course, right, that are producing these CGRP blockade products, whether abortive or preventative GPANTs or preventative CGRP monoclonal antibodies, to kind of say these drugs aren't really that good anymore because you have to titrate up to reach an effective dose. That takes a lot of time. Patients are impatient. You have to cycle through a few before finding the most effective dose. And of course, it's true, the older drugs do have higher adverse effect profiles, but they've been around for a really long time, and we have better understanding of their long-term safety profiles. The one anti-CGRP monoclonal antibody that has the best long-term safety data is Aimovig. And the others don't really have their 5-year safety data in yet. So we're still waiting on that. But that's still short term, right? Like we want to know what the effects are 10 years down the line, 15 years down the line. And these therapies are much too novel to have that information as of yet. And they can also help in treating associated symptoms, depression, anxiety, seizure disorders. So they can be managed synergistically with all the other medications that are new. But we can't forget Botox, right? Because we do Botox here at Abington Neurological Associates. It's incredibly effective. We do have long-term safety data on this stuff. It was initially identified as a potential migraine preventative after people who were getting it for cosmetic reasons were like, hey, my migraines are feeling a little bit better. Should we study this? And they studied it on the episodic population initially. It wasn't really effective. And then they studied it on the chronic migraine population, greater than 15 migraine days per month. And it was effective. And in the year of 2010, the FDA approved it for headache prophylaxis in adults with chronic migraine. And this is administered every 3 months, every 12 weeks by a licensed practitioner, either one of our PAs here at Abington Neurologic or one of our neurologists. And the best thing about it is that you don't have to take it every day. But of course, you actually have to come in, and there's an added expense of going to the neurology office, but that's okay, because we could also kind of localize the therapy a little bit and optimize it for your care. If even though headaches are not very localizable, we could optimize, give you a little more injection in the back of your head, a little more in your shoulders if you need it, and kind of work with you as the follow-ups mount up to specify your plan of care. So future directions and the focus of future drug targets. Serotonin is very interesting because we have these two drugs now over the course of the last 30 years now that have manipulated the serotonin receptor sites for abortive migraine relief. You've got the triptans in the early 90s and now the ditan drugs, and they're great for specific patient populations. But we're waiting for that prophylactic drug, that preventative drug. We don't have that yet. And the experiments are ongoing. The trials are hopefully going to start within the next few years. It's still in the lab phase. Pituitary adenylate cyclase activating polypeptide, that's a mouthful, but it's also a possible target for migraine prophylaxis because exogenous PCAP, when you give this to patients, it triggers migraine. So blocking it might be an answer to a cure. Orexin, it plays a role in wakefulness. It affects kind of thalamic pathways. We're trying to see if that plays a role in cortical spreading depression. Glutamate is an excitatory neurotransmitter that might play a role in migraine, and kind of manipulating that may be beneficial in the future. And we have another few things that may be manipulated in the lab and hopefully extrapolated into migraine trials in the near future. So the hope is there. The future is bright. Right now, we're doing trials, clinical trials here at Abington Neurological Associates, and are in open enrollment. We're actively enrolling for patients to help us figure out how to change treatment modalities into the future, not only to help this generation of migraine sufferers, but future generations of migraine sufferers. We have two active studies. We have something called the Preclude study, which is a phase 3 study looking at Botox for the prevention of migraine in patients with episodic migraine. So that's less than 14 monthly migraine days. This is a drug, a toxin, which has been effective in treating patients with chronic migraine, as mentioned before, but not episodic. So we're recruiting patients into this trial to see if it's effective. If you're interested in this, please give us a call and we'd be happy to screen you for active participation. Another study that we're very excited about is a phase 4 multi-center open label study to evaluate the safety, tolerability, and efficacy of the use of ubrogepant and atogepant taken concomitantly. So I'm going to unwrap that a little bit. Atogepant is Qulipta, ubrogepant is Ubrelvy. Qulipta is the Gepant that you take on a daily basis to decrease the number, the frequency, and severity of migraines over time. And the ubrogepant is the abortive drug you take to knock out the headaches that you get during that period of time. Does taking both of those help? And is that tolerable for patients? Because when you add two Gepants together, could there be an increased risk of side effects like nausea, like constipation, like somnolence? This is the trial that'll figure that out. So we are actively enrolling for this. Dr. Klein is the PI for this trial. I'm the PI for the Preclude style. We're working real hard to kind of push forward migraine care into the future. And the long-term prognosis is good. We truly believe that. We truly believe while we can't cure you, we can help control your disease. There are plenty of places to go to ask for help, not only here at Abington Neurological Associates, but at the American Migraine Foundation always has resources, as well as the American Headache Society. It does tend to improve with age, especially if linked to the menstrual cycle, particularly if you can avoid hormone replacement therapy. The younger men have more migraines than older men. So there's definitely a decrease in migraine as time goes on, not just in women, hopefully, but men as well. And we, over the course of time, consider prophylactic medication withdrawal as patients grow older. So that's just a reflection of the fact that hopefully migraine will decrease in most patients as time goes on. So something to look forward to, as well as our persistent care and perseverance in treating you. So in addition to treating migraine and other forms of headache disorders that were outside of the scope of this discussion, we offer a wide range of diagnostic tests and procedures here at Abington Neurological Associates. We do Botox. We do home sleep studies. Sometimes an untreated and undiagnosed sleep apnea can make migraines worse, so that's really important. We do EEGs to evaluate the risk of seizure or seizure tendency. Infusion therapies like Vyepti are provided here, but we also do other types of infusion therapies for multiple sclerosis, for example. And we perform EMG and nerve conduction studies all the time for peripheral nervous system diseases. And like we mentioned before, we do a great deal of clinical research, not only in migraine, but in Alzheimer's and Parkinson's and multiple sclerosis as well. So with that, I'd like to stop and open it up for questions. Thank you so much. Is there anything I could help answer?
Dr. Factor, we did have one question from one attendee. They said they much needed vestibular migraine help. Do you have any?
Yeah. I'm much needed vestibular migraine help?
Yep.
Get appointment?
Yeah, absolutely. Is this it's a current patient at Abington Neurological? I would certainly be happy to help in this situation, but vestibular migraine is complicated. That vertigo is a frequent aura manifestation of migraine. It can certainly be treated with associated antiemetic or medications. Oftentimes we'll send these patients to vestibular therapy to see if it helps. And I have seen a good amount of patients have a concomitant BPPV diagnosis. So that can oftentimes be a clue into an associated diagnosis that can be treated. So it really kind of depends on a kind of a case-by-case basis. So that's kind of probably the best way I can answer that question. Are there specific medications to treat specifically vestibular migraine? I wouldn't say so. Sometimes antiemetics help though, and meclizine can help as well.
Thank
and
you, Dr.
sometimes
Factor.
benzodiazepines as well.
We have another question. Karen's asking, cluster headaches are not migraines. Can you expand a little bit? You said cluster headaches are not migraines.
No, cluster headaches are a little bit different. Cluster headaches are shorter and often seasonal, and frankly, a little bit more severe. They are often triggered at a specific time of year, and while oftentimes unilateral, can happen in very short jolts, 15 to about 180 minutes. So there's a shorter kind of time span than migraine, and often don't have a preceding aura either, and often don't respond to preventative medications that are used in migraine. High flow oxygen is used. Galcanezumab or Emgality infusion therapy, monoclonal antibody injection therapy is used during those periods of crisis when patients experience this. And sometimes triptan drugs can be helpful as well, but it's a slightly different mechanism than migraine.
Thank you, Dr. Factor. Maria is asking, please comment on cephali treatment and efficacy. And if I butchered the name of it, I apologize.
Yeah. Sorry, a lot of this stuff I would have commented on. It's just outside the scope. But cephali is a supraorbital stimulation. It's frankly, I came into migraine headache practice in 2019. I'm actually an epileptologist that kind of moved into migraine care. I don't have a great deal of experience with cephaly. I do know that just kind of anecdotally, patients have never really seen a decrease in the frequency of migraine with that particular supraorbital stimulation device. It's something that kind of goes over the front of the head and stimulates the head and decreases the severity of migraine more so than the frequency of migraine.
Thank you, Dr. Factor. We have another question, and this will probably be our last question, unfortunately, because I do know you have a hard stop. If you do have a bad reaction to one of the migraine medications, especially an injectable, is there a way to mitigate it, or do you just ride it out?
It really kind of depends on the severity of the reaction. And again, it's more of a case-by-case basis. Unfortunately, the half-life of these injectable medications is rather long. It's about a month, right? It doesn't necessarily mean that the side effects will be severe, but because they aren't based on the long-term data. But for the most part, there's no way to pull out those monoclonal antibodies from your body. So if I were forced to answer that question, you may just have to ride it out. But there are ways to therapeutically treat, but it really depends on the specifics. So I don't know if I can answer that question directly.
And then there's a question about EEGs and whether an EEG shows anomalies compared to baseline during a migraine attack.
Yeah, so 2 ways I can answer that. So an EEG does not, even though there is something called that cortical spreading depression, which is the wave of depolarization coming over the brain, studies have not shown any changes in scalp-based EEGs during that period of time. There have been some studies that have showed that an EEG is a little bit slower. The brainwaves can go a little bit slower, especially in the posterior portions of the skull or the brain, during a migraine attack. But that's not indicative of any kind of brain damage or tendency for further seizure activity, for example.
Thank you. Another question regarding a medication. Medicare does not cover Ubrelvy. Is there another option to reduce cost? In other words, is there another medication other than Ubrelvy that's as good as Ubrelvy that you would recommend or suggest?
Yeah, so there are 2 ways to answer that. Number one, Ubrelvy is now working, and this is very recent, with Aspen Pharmacy, like ESPN, the sports website, but spelled wrong, A in the front, A is in Apple, right now to really help cater to patients both with commercial insurance and on Medicare and Medicaid to make the prior auth process a little bit easier. And AbbVie, the pharmaceutical company that makes Ubrelvy, is also working with patients to make the cost basis a little bit lower for them. So that's a boon for those patients. The other medication that can be used as a substitute is probably Nurtec. I mean, it has a very similar mechanism of action. The only real difference is that it's an orally disintegrating tablet. So it's kind of like a mint melted way. And it has a slightly longer half-life. So you can only take it once a day, as opposed to Ubrelvy, which you can take twice a day, separated by 2 hours.
Thank you, Dr. Factor. And then our last question, this individual got 4 years migraine free after 12 sessions of acupuncture treatment. Multiple stage lights flashed in eyes, ended that streak. I'm notoriously light triggered. Do you have any experience with acupuncture? And is there a pattern as to what else, works drug-wise for those who get relief from acupuncture?
Can you read that, Dave? Can you read that last sentence again? What works with that?
Do you have any experience with acupuncture, and is there a pattern as to what else works drug-wise for those who get relief from acupuncture?
Got it. I have seen anecdotally some improvement in patients with migraine after the use of acupuncture, but it's not really an FDA-approved modality for migraine treatment. I am never really against it. I don't think it's dangerous. I am more than happy to let patients become empowered in seeking out new modes of treatment, as long as they're not harmful and as long as they discuss them with me beforehand. With regards to the photosensitivity, there are no medications to treat patients, first of all, that have that are specifically designed for those who improved with acupuncture. With respect to the photosensitivity and severe photosensitivity, if that's important, because it seems like it might be, there are sunglasses that specifically filter out a large amount of dangerous light that can cause severe photosensitivity, both indoor light and outdoor light. And those are called Theraspecs. They're not even that expensive, and they can be made into prescription sunglasses as well. Theraspecs, T-H-E-R-A specs, THERASPECS.com. And I recommend those to a large majority of my patients who have severe photosensitivity. So that can help treatment-wise going forward.
Thank you, Dr. Factor. That's all the questions that we had. I'd like to thank all the attendees for attending today. And if you need anything, please reach out to Abington Neurological Associates. Everyone have a wonderful day.
Thank you so much.